move forward to track 6 of our conference. The theme of this session is Diagnostic and Medication Safety in Pediatric Care. We all know that caring for children requires the highest degree of vigilance, precision and responsibility. Even the smallest errors in diagnosis or medication can have profound effects on the young lives. This session will shed light on strategies to enhance safety, minimize errors, and strengthen systems that safeguard pediatric patients. To lead us into this crucial discussion, may I now invite our esteemed chairperson, Madam Ms. Pinky Bayan, Ms. Pinaki Bayan, Chief Nursing Officer, Apollo Hospitals, Guwahati, and Apollo Excel Care Hospital, member in ANEI. I welcome you, ma'am. I also invite our respected panelist, Madam Dr. Rachna Das Hajarika, Senior Consultant Pediatrician, Guwahati, Madam Dr. Parul Datta, Retired Principal Nursing Officer, West Bengal Government Nursing Services, and Madam Lieutenant Colonel Vasundhara Pal, Nursing Officer in Charge, OT, IMHS Ashwini, Mumbai, member ANEI, to take the stage and share their insights. Let us all welcome them with a warm round of applause.
And very happy to be in this auditorium, and thank you ANEI and organizing team for organizing such a beautiful forum. But to be very honest, I don't know what to say. Just now seated here with such a bad news and not able to really talk any sentences, and I think all of us we know he is one of the persons to whom I don't know how to go ahead with this session. But anyway, we need to continue our job, and then I hope any member has arranged some kind of condolence maybe soon after this program. And yeah, so. Once again, let us come back, because I understand nobody will be able to concentrate being from Northeast, but then it's important to learn, and so must go on. That's a dialogue, we need to do that. This particular moment, it's a really a moment to talk about patient safety, and we observe patient safety week. Now we are talking about month as a September. And also the day was 17 September. Today, 19 September, we are discussing many important points, and one of the important track probably we have to really look at very differently, that diagnostic and medication safety in pediatric care. So far we talked so much about adult care, but then I think this year that team itself talked about newborn and children care. With that, yes, I'm very privileged, to be honest, allowing all of you to introduce such eminent personality who are with us as a panelist. To start with, if I have to talk about most senior person, with us, Dr. Parul Datta, ma'am, it's a profound gratitude, and very fortunate to be with you at Guwahati. We Guwahatian and Assam Northeast people, maybe we all know about you because we read your book, and whenever we talk about Parul Datta, it comes as pediatric, So we are so privileged to have you here, ma'am, and your input towards safety of children in terms of these two aspects. One is the diagnostic error, and other one is the medication error. So I'll be very happy if at all you can proceed for your presentation, ma'am.
Okay, thank you, madam, for my introduction, and thank you everyone for being here. I think I am having some slides. My slides can be shown? Excuse me. So, many thanks to ANEI and the organizing team for giving me this opportunity to say something regarding the patient safety, especially for the newborns and for the children. So regarding diagnostic safety, so we can say most important thing, it is critical and crucial for the patient safety, to maintain the diagnostic safety, especially for the newborns and children. And next slide, please. So welcome. And there is, we know that there is various diagnostic interventions that can be invasive or non-invasive. And from the basic study of our nursing curriculum, we know that for the diagnostic evaluation, we have to collect the medical history in details. We have to do the thorough clinical examination. We have to collect data related to laboratory investigations, especially from the blood and other body fluids. And we have to perform, now we are in the technological era, so we have to perform so much technological diagnostic evaluation through using the technology. So with these only, we can come to a conclusion and maintain the safety for the patient, considering the hazards of these diagnostic interventions. So next slide, we know that improvement of diagnostic process is very critical, and we have to maintain the safety of the patient, and we have to prevent the diagnostic errors and harms during our diagnostic evaluation process. What are the diagnostic errors we found in the clinical area for the old patient? That is mainly the missed diagnosis or delayed diagnosis or over-diagnosis or wrong diagnosis, or sometimes not doing any diagnosis, especially in the rural population and where the facilities are not available. So from the Western data, we can find out that about 60% of the patient harms occurs due to the diagnostic errors. And that occurs due to missing details of the medical history. We don't have the healthcare provider and personnel, so we don't have that much of time to collect details of medical history, especially the huge population of the pediatrics group. So that's why the medical history missing. And family members, they are not able, sometimes they are not able to understand what information to be given to us and what not to be given. And we are also in hurry. So that's why medical history, if it is not taken, then there will be no proper diagnosis and there will be diagnostic error. And another important area is clinical examination, especially in emergency situation, in triage way. Sometimes the medical professional, doctors and nurses are doing a quick clinical examination, and that missed so many important points, especially the newborns and children. Those are not able to speak themselves and their problems quite clearly. So another important is lack of communication, inefficient communication, and equipment failure, lack of well-trained personnel. Even technicians are also not well-trained about the use of technological equipments. So with these, there are so many diagnostic errors, and this is our commitment to reduce the diagnostic errors and to prevent the harms for the patient, newborns and children. So in the next slide, I'd like to highlight about the challenges of pediatric diagnostic safety. The major three challenges. First is the changing anatomy, physiology and developmental variability that present a most important challenge. The newborn's anatomy and physiology and pathophysiology is totally different from that of older children and adult. So we have to be very much thorough about this changing anatomy, physiology, developmental variation and pathophysiology. Then only we will be able to diagnose safely. And another important point and challenge is that young infants and children, their signs and symptoms are non-specific. All the illness are having common signs and symptoms, and that makes us confused during the diagnostic evaluation process. So, and sometimes not only the young children, neonates and young infants, they are not able to articulate their symptoms due to their limited verbal communication. So we have to be very good observer to find out the signs and symptoms and clinical manifestations, because the children, they are not able to say what problems are they are having. So this is a most important challenge for the diagnostic safety. Another huge and high workload of huge pediatric population with huge pediatric illness, and there are so many preventable aspects, but till now they are the most sufferer. And the lack of access of complete health records. That even if records are available, the computerized records are not available in our country, especially in the rural area. Even in the public sector, it is very difficult to get all the records for the children. If the children are coming for the second visit, we are not able to find out all the data. Another non-availability of the modern facilities is also another challenge, and frequent interruptions during the process of evaluating process, that also may give us some challenge for diagnostic safety. So what strategies we have to follow to overcome these diagnostic challenges and safety? First, we know from the very beginning morning we are listening about the involvement of the family members and parents, and for the older children also, we can engage them. Comprehensive data collection for the diagnostic journey for history, physical examination and laboratory investigation, radiological imaging, that should be done. Health workforce must be skilled with their preventing the cognitive errors by the training and continuing education program. That is very important. We have to be very much up to date, and that's why this type of continuing education program, conference and workshops are very important. And we have to follow the standard guidelines for diagnostic evaluation and communication protocols. And we have to follow the standard quality improvement project for the safe diagnostic evaluative process. We are now following not the quantitative service for the pediatric population. We have every point of care, we have to follow the quality improvement, and then add diagnostic technology with precautions. Like whenever we are using the CT scan, there can have radiation hazards. Whenever we are doing the repeated blood sampling, there can have some, especially for the newborns, like they can be suffer from the infection or the less blood related problem. So that we have to consider that aspect also. Then now we are in the not only in the technological era, we are in the artificial intelligence era. So we can take the help of the artificial intelligence for decision making regarding the diagnostic process. Another strategy, what we are in the emergency situation, we have to take most important how to manage the emergency situation. That emergency medicine is now a emergency as a new subspecialty. So we have to learn how to manage the emergency setting, and we have to follow the checklist and decision support tools and multidisciplinary collaboration and some expert consultation, team approach we have to follow for diagnostic safety and prevent the diagnostic error. And point of care testing, now we are giving more emphasis on the bedside X-ray, portable ultrasonography, and the screening protocol for the newborns like ROP, OE, hearing screening, that is OE, VERA, and pulse oximetry. With the simple pulse oximetry, we can identify the critical congenital cardiac heart disease. So other than that, with IEM, involved error of metabolism, this screening protocol helps to detect the disease condition early. Congenital anomalies under the RBSK protocol, we can follow this diagnostic approach also by screening. There are standard protocol in the Western now, we are in our country also, that is congenital hypothyroidism, then congenital adrenal hyperplasia, G6PD deficiency. This type of diagnostic screening protocol we can follow for the early diagnosis. And most important is, for doing all these things, we need funding and we need advocacy. Newborns and young children are the innocent victim of all these different disease patterns. So it is our responsibility to do the advocacy and funding for research and training, for early identification, to prevent diagnostic error, and to also foster the family-centered care and community involvement to improve the health literacy. So these are all about my diagnostic safety thinkings. So for diagnostic excellence, we have to reduce the unnecessary testing and overdiagnosis, and we have to promote the diagnostic stewardship. Everybody should be aware about this, and we have to prevent the misdiagnosis and overdiagnosis. Thank you regarding diagnostic safety for the pediatric population. This is all about my thinking.
Wow, such a elaborative discussion she has brought to the forum. Thank you so much, ma'am. You have put across so many points which are so important. And to me, there are some catchy words. One is the prevention of cognitive error. I think this is the way we need to look at, and we need to have a lot of training on the subject, and we can eliminate those errors probably. Number one. Ma'am has mentioned we are in an era of technology. We need to utilize artificial intelligence, the process towards how to deal with the problem. More importantly, I think we can prevent by having a lot of apps and a lot of technology, so that we can go ahead to have a much better environment. The third thing, I think we talk about genomics now, we talk about genetic counseling, so those things are upcoming, and India is practicing in many areas to identify anomalies, congenital anomalies, so we can reduce the problem. As well as I brought some statistics where it talks about the diagnostic error stand in the hospital more or less 7% of the baby who comes to our hospital. 7 is a huge number. Out of 100, 7 of them are having the misdiagnosis. There are many studies. One of the studies, it is setting-wise where it is conducted actually in India. Indian study very difficult to get and having data. But this is a study done in 2023 in Andhra Pradesh. It talks about 3 to 12% high risk baby comes to emergency are having misdiagnosis. So that's very, very bad. And it is much more higher when you happen to go for autopsy. So that comes again 20%. So that's very, very scary data. 2025, there was another study which was conducted in India, and it talks about 2.6% kind of misdiagnosis from that is measured. And out of that, half of them seems to be very fatal and having mortality. So very, very scary, ma'am, to look at that. So anyway, we need to work on, and thank you so much for bringing out many points here. So coming to, I'm so privileged along with all of you that we have got another very, very focused, eminent doctor, Dr. Rasna Das, and who is from this soul, and then she has completed her MBBS, and she was a gold medalist, and reflected in her brief CV. She also have completed her MD Medicine in Paediatric, as I remember, from a very prestigious institute called PGI Chandigarh. She has done one more additional very special course for Paediatric from PGI Chandigarh, and she was the founder pediatrician for one of the very esteemed institute which is called NEGIMS in Northeast India. She also have actually contributed while NICU PICU was built in NEGIMS. She has developed protocol policies how to deal with the newborn and lot many things, and she is with us today. So let us hear from her how to look at the diagnostic and medication error for children, ma'am, from medical perspectives.
Thank you very much to all of you for inviting me here. Actually, I feel like the odd person out, but I think I was looking at the presentation before this particular topic, and I was so impressed. All the papers that you have done, even doctors are not doing that kind of research. So that is one of the things which is very, very important in any patient or health care. It's a collaboration between the specialities, whether it's between two specialty doctors, or between the doctor and nurses. And I think that is one of the most important aspects when you talk of not only diagnostic error, but even medication error. So diagnostic error, I think Parul Baidu has already told us in detail that so many things can happen in so many different ways. But I agree with her in the fact that we are so overloaded with patients. If you ask a pediatrician who is working in the government sector as to how many patients you have seen in the whole day, say maybe 6 hours, it usually crosses more than 100. So how many minutes are you giving to each patient? We are not. Hardly 1 or 2 minutes. I have heard of situations even in Assam, in nearby CHCs and PHCs, where the pediatrician is having 3-4 patients together in the same room, and then before the mother is able to open the mouth, the doctor is already writing the prescription. So where is the diagnosis? So there is error right from the beginning. So I think we are overburdened with the fact that we are having the doctor-patient ratio is very bad. Though the government is trying to bring it to the WHO guidelines, but we have not succeeded. And as Dr. Parul has said, we are overloaded with pediatric patients. Parents come late, so many a times that is one of the reasons that the diagnosis gets delayed. Sometimes they come to us, and then there is also a tendency in our country that you do a lot of doctor shopping. So what happens if you come to me the first day, you have a day 1 of fever, and I tell you just hang on, wait. No, they will go to another doctor and try to get some medication. But if that doctor also doesn't agree, they'll go to the pharmacist and get over-the-counter medication. So sometimes when these things are done, then the diagnosis of a particular ailment becomes a problem for the treating doctor. See now, before I think if you read even your books, if you say for malaria, for typhoid, it's a very particular pattern of fever which is described. I'm giving you a very simple example. So if you have, say, cerebral malaria, the fever will be different. If you have malaria because of vivax, the fever pattern is different. According to the books, in typhoid fever, you call it step ladder. Slowly, 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 it will rise. But in my practice, in our clinical practice now, we don't see those kind of things. We cannot diagnose because paracetamol is given even at 98 degrees centigrade. Understand? So 98 degrees, sorry, not centigrade, 98 degrees Fahrenheit. Mother will say, this is Iman Jor, but Iman, how much is the fever? 98.4, but that's normal. So one is, as Madam has already pointed out, the lack of knowledge in our society. The other fact, you are talking of AI, but there's another aspect to that parents are using AI and then they're getting into the wrong kind of information. So if they will not believe you, but they will go on believing the YouTube or somebody's video which is very popular. So they will medicate according to that, and then again it involves in delaying or changing the pattern of the illness, and therefore a delayed diagnosis, or sometimes you're not able to diagnose. And many cases like that happen. I'll tell you my example. Now India is a country which is so vast. It is like many countries in one whole country. So I was, as Madam has said, I was doing my post-graduation in Chandigarh, which is in the northern part. And when you have fever, hepatosplenomegaly, the most common diagnosis there is typhoid. And then what happened, I got shifted from there to Shillong at Negrims. So my typhoid brain was still active. And then I saw this girl with fever, hepatosplenomegaly, and my diagnosis was typhoid. So I sent all the investigations related to that particular condition, and the pathologist rang me up because I had sent a CBC with a peripheral smear. So she rang me up and said, Dr. Rachna, you know what, your patient has falciparum parasites in the peripheral blood smear. Now that was a learning lesson for me because I did not think of malaria, where in spite of coming back to a highly malaria endemic area at that time, 2004-05. So this is the kind of thing in our country because there are so many different areas, so many different regions. Even we, with our knowledge also, sometimes we don't, apply that when we change places. So that is one of the examples I'd like to tell you as far as diagnostic errors is concerned. Anything else you want to ask me?
Thank you, ma'am. I'll come back to you if the time permits. Yes, just to tell all of you, very recently I was just reviewing one of the study, and then a very catchy one of the paragraph is that is advice, piece of advice in this study saying that when you meet a doctor, particularly pediatrician, you better go along with the medication, whatever is administered or being administered to the baby, and with the correct level and the original level of either syrup or whatever form medicine is there, and you show the doctor exactly, not saying about that I know that this is the medication I have given to my baby. That is not advisable because many occasions, as ma'am is saying, google.com, AI use, so that become more scary. So it is always advice, and as a nurse, I think in a community, we need to talk about it that whenever you seek help to a pediatrician, if there is any medication baby is already receiving, go along with the medicine without having any kind of transfer medicine to one box to other or from one bottle to other. That's help. And yes, ma'am, doctor nurses demand in India is definitely, that there is another discussion required. Ratio is nowhere up to the mark, so we are struggling. So thank you once again for putting so much of input, and I hope we'll be able to learn out of it. Coming to the most hybrid, and it is very unfamiliar to talk about your profile, ma'am, and who is with us, Lieutenant Colonel Vasundhara Pal, and very, very vibrant lady for knowing the subject, how the newborns are taken care of right from the OT, and then how it is managed newborn during that particular phase. And to tell about that, ma'am come from the Navy background, as I am
Ma'am, I'm from the Army background.
Army background.
Yeah, I'm
Okay.
presently deputed as at a Navy hospital, which is
Navy
located at
hospital, yeah, you are from Army background, and currently working as a OT matron.
I'm nursing officer in charge OT.
Okay, nursing officer in charge OT, correct, in Asbini hospital, and she is going to tell us about how to look at the safety of newborn baby, and more importantly, how to minimize the risk for newborns right from the operation theatre, ma'am. Thank you.
Thank you, ma'am, for the introduction, and thank you for the very rightly asked question. So the newborns, when we talk of the protocol in the operation theatre, there are numerous number of aspects that we have to look for, which starts from the physical setup of the operation theatre, that is the structure of it, the walls of it, the kind of windows it has, the air exchanges unit that it is supposed to have. So the temperature, let's say temperature regulation has to be from 18 to 25 degrees. Then coming to the humidity, it is 40 to 60%. Then it should have high efficiency particulate airway exchanges. The wall should be creaseless, the floor should be creaseless, and also skid free. So a bit about the physical infrastructure of it. Then coming to the type of atmosphere that we have to give, it is supposed to be a near, or you can divide it into ultra clean zones depending on the type of surgery that the newborn or the child is undergoing. So to these temperatures may not be very favorable for the newborns or the children. So accordingly we have to have the support system, that is we should have the warmers, adequate warmers at the right place should be there. Then coming to the infection control, before infection control I would like to say all the equipments should be functional. There is no probability which is expected to be there for the non-functional equipments. So it is a very high responsibility for every individual who is working should be trained, repeatedly trained, and the checks and the examinations of the training in the operation theatre is zero error, which is supposed to be there. So the training is supposed to be is supposed to be of a very high standard. Then morning we all come, we check the equipment. If it is not functional, it's our responsibility. We give it up and get it replaced. So that is, in cases of children, is non-forgivable. It has to be functional. Then coming to the sterility, as you all know, OT is known to be and it is supposed to be sterile zone, wherein there are three aspects which we all should follow is hand hygiene, non-forgivable if not done. Coming to the hospital-acquired infection-related initiation which may take place in the OT is nearly not acceptable, especially in cases of cardiac and ortho. Cardiac and ortho, if it gets infected, these patients get infected, it is very difficult to get them back to normal. And more so if it is there for the children and newborns. Then coming to the, this is about the skin. Then you have your tradition of safety concerns and the customs that we have. So in these, the culture that we follow is you all are supposed to be communicating everything, like we are giving drug. There is a high probability of getting the medication errors. There are so many medications, and like in the ward, there are a number of medications which are there, which are all, so, almost all these medications are high alert. Like in the ward, we have a few drugs which are high alert drugs, but in the OT, it is a huge number, which is maximum is of the high alert proportion. So every single drug which is prepared, especially for the children, has to be rechecked and rechecked twice or thrice by the anesthesiologist and the ORT who is there, or the nurse who is there. So the dose which is prepared or diluted for children is rechecked, and before infusion, the it is a zero error which is accepted when it is related to the muscle relaxants, say induction agents, say sedatives. So these all things are there which can happen and can lead to a very disastrous result. So these are the factors which we need to take care, and also the newborns when they are born, we have set up wherein every unit is when the mother comes, we check the features of the patient, and in between when the spinal is given or the mother is undergoing cesarean, soon after that there is the present scenario is we give a delayed cord clamping. So that is supposed to be followed in most of the hospitals, and until unless they are doing some research, otherwise the delayed cord clamping is recommended. So then when the baby is born, the temperature, as I told you, it is not maintained at a temperature which is very newborn friendly. So again, the warmer has to be prepared before the patient is undergoing cesarean. And when the baby is extracted, complete, as Ma'am Parul also mentioned, we tend to do a quick examination. That should not happen. Quick examination, when the baby is born, we have missed, as both of our senior faculty has told, with their experiences, they must have found a large number of diagnoses which are missed out. So this should not happen. As youngsters, you should take home. The quick assessment thing is to be not at your level. Whenever you are taking, you should be taking a thorough examination when the baby is born. Even I have experienced the TEF is very commonly, the congenital anomalies are very commonly not diagnosed. So these are the few things which we tend to miss out if we are not very careful. So these are a few aspects which we have in the protocols. Hand hygiene and biomedical waste. Hand hygiene is the first and the foremost step which can take us to a healthier zone or to a fatal zone. So healthcare, every single healthcare member who is working in the OT or in any other department has to be very clear that it is the final step. This is the most efficient step which can prevent infections, and this is the only step which can lead to a full-blown sepsis. So that you must take home this message, and everybody in the OT, we do follow. And how we ensure it is, how do we get to know that we are doing it? For that, the audit and surveillance is very important. There has to be always a regular practice of auditing and surveillance, so that whenever there is a loophole that we find, can be again redone. Plan, act, do it and reassess. Keep assessing it, and you should come to a conclusion that every single member is following it. And this is all I would like to say.
Okay, thank you, ma'am. I have done a lot of work on how to prevent the error. In there is two aspects. One, in the dosing, either it is overdose or underdose, or next is the wrong medicine itself. So these are the areas which we need to work on. And actually, I'm getting alert. We are out of the time, but thank you so much. All of you have put excellent points for learning, and this will surely help all the participants to learn in brief how to take care of diagnostic error and the medication error. Medication error we do talk very commonly, but for pediatric it is little different. But I really want to tell one more thing, that whenever doctor prescribes something which you don't understand or you have any doubt, please come back. Do not hesitate to ask, especially when people write decimal. Suppose 2.0, that's very, very bad prescription, rather it should be 0.2. It's an example. So I request all the participants to be very careful when you work in pediatric setting and dealing with diagnosis and diagnostic procedure, as well as when you deal with, more importantly for nurses, is the medication administration. Thank you once again.
And thank you. Just a few slides I'm having, I can just within few, I'd like to just highlight some important points. So just a few slides, just a little one. So there are so many medication techniques are there, so non-invasive and again invasive. So medication, next slide. So there is medication safety. For medication safety, so first we have to involve the all necessary precautions to ensure, already we have told, most important threats are the medication error and adverse medication drug reaction or drug event, misinformation, poor storage and destruction during medications. So we have to overcome that all. And medication error actually includes the prescribing error, dispensing error, transcribing error, administering error and monitoring error. So we have to overcome all these. Next slide. So medication error are most common for the hospitalized patient. It can happen in the home also. And it is most vulnerable population are the neonates. 84.2% medical error happens in the NICU, and majority of the errors is the medication writing error. So we have to be conscious, everybody has to double check, we have to do, already it is highlighted. And serious error is the prescribing decision error, what drugs to be prescribed. And that's why it is found that 3 times more commonly medication error is found for the pediatric population, mainly in the NICU and SNCU and PICU. Next slide. So it is our shared responsibility between the parents, caregiver and the patients, older patient and the healthcare professionals. So clear communication, accurate information and error prevention should be followed. Safe storage should be done in a child-proof, dry, cool places and out of reach and out of sight of the children. Safe use of medication by the prescription by the doctors or over the counter should be administered according to the body weight, not always of the age. Already Madam has highlighted, so according to the body weight. We have to remember that too little medicine can be ineffective and too much can be harmful. So we have to avoid unnecessary medication use also. We have to check the expiry date every time before and after before use. Next, we have to follow the rights of the medication. Next slide. Rights of the medication administration. Previously it was 6 rights, then it came 10 rights, now it is 16 rights. So we have to follow that. Double check we have to always do for the dose calculation and child's identification. Sometimes one child can be misidentified, so identification is very important. Look-alike and sound-alike drugs should be very cautiously used. And checklist or standard operating protocol should be used for the medication administration. These all are the nursing responsibility. Injection safety should be consciously practiced, especially for the IV injection. If it is administered by the for the antibiotic, that should be used to administer using the syringe pump. And usually for the newborns, it should be administered by 30 minutes. So this type of instruction we have to follow. And the skin preparation, start the half of 15 seconds, that also we have to follow for the quality improvement of and prevention of antibiotic resistance and drug resistance. So irrational use of antibiotics should be prevented, safe discard of unused drugs should be and medications should be practiced. An integration of clinical pharmacist is very important. Western country it is practiced but not in our country. Next slide. Regular reporting of adverse drug event and medication errors should be done honestly. We should not hide that medication error. And blood testing should be done if any drugs are used for long term. That is very important to prevent the adverse drug reaction. Specific data is not available, especially in our country, about the adverse drug reaction problems. Another important is pre-marketing, that is done but not effectively done. That is pre-marketing assessment of medication safety that we have to ensure by the manufacturer and from the drug regulatory agency. Post-marketing monitoring of the medication safety also should be done. An instruction for the use of medication by the caregiver at home for the long-term medication should be clearly written in the preferred language, and awareness generation, not using the use of drugs from the Google and the over-the-counter medicine should not be done for the pediatric population to prevent the adverse reaction. And we have to make them aware about the unnoticed interaction about the traditional medicine and homemade remedies. Majority of the population we have found in the rural area, they are using the homeopathy and allopathy or traditional medicine together. So there can be unnoticed interactions of the drugs, and that can lead to so many medication error and harms for the pediatric population. So for the medication safety, use it right. Close the container of the medication tightly out of the sight of the children. Thank you very much.